Hello. In the second slide, we will be showing about the assessment of preload and cardiac function by ultrasound. So, assessment of systemic perfusion can be done by clinical assessment using blood pressure, heart rate, or capillary fill time, or measuring a urine output or serum lactate. We also can use NIRS or echocardiography for direct left ventricular output measurement, especially in events, in the cases where there is no specific steal phenomenon by a shunt. Or we also can do an indirect measurement by measuring the right ventricular output or systemic venous vena cava flow or any organ Doppler blood flow to assess the evidence of any systemic perfusions. So just a little bit about the stroke volume. So when we talk about cardiac output is nothing but the stroke volumes times the heart rate. And the stroke volume does depends on the how much preload, how much is the preload in the heart along with myocardial contractility. These are quite intercorrelated. Similarly, myocardial contractility and systolic function is also related to the how much is the afterload, nothing but the systemic vascular resistance. In addition to that, we need to know how much is the adequacy of myocardial relaxation during the diastolic phase of the cardiac cycle, which otherwise known as diastolic function. So both diastolic function and systolic functions are quite correlated, similar like preload with the myocardial contractility. So let's look at what is a preload. Preload is the amount of blood filling in the ventricles during the diastole. As by the Frank-Starling's law, as the preload increases, there's an increase in the stroke volume to up to a maximum volume, beyond which the stroke volume start falling. So how to assess preload by ultrasound or echocardiography is that one, we can look at the filling of the inferior vena cava and the collapsibility of it, and second is by looking at the apical fourth chamber by looking at the filling of the ventricles both during diastole and the systole. So first look at the inferior vena cava size. So for performing the inferior vena cava assessment, we can look at the subcostal sagittal view. We're looking at the inferior vena cava draining to the right atrium. So this is the subcostal short axis view where you can see the inferior vena cava draining towards the right atrium. Important to note that the inferior vena cava is distended. At the same time, the contractility, basically collapsibility and the distensibility depends on the breathing patterns. For example, during inspiration, where the intrathoracic pressure increases, there is a decrease in the caliber of the inferior vena cava, and during expiration, there is a filling of the inferior vena cava, so you see more distension. So this is how it looks like. This is the inferior vena cava. As the inspiration starts, there is a narrowing of the inferior vena cava. Once the expirations, then they remain patent to refill. Sometimes the Doppler, the M mode of the inferior vena cava, might also help in calculating the diameter of the inferior vena cava at maximum diameter as well as minimum diameter, and can calculate what is called distensibility index. That's the maximum diameter minus the minimum diameter over the minimum diameter. That the normal is considered about 18%. More important than that is often it's just how the visually we were able to see is the IVC collapse, completely unable to visualize, or is it distended with partial collapse, or is it distended and hardly collapsing. So for example, this is the inferior vena cava showing well fill and the contraction of the IVC. So normally during inspiration we expect the collapse of IVC to less than 50% of the original diameter, and the distension again varies depending on the size of the baby. But what's a normal sometimes is difficult. So for example, in this view, if you see this is the right ventricle, which is right atrium, and this is the inferior vena cava. As you see, it's very well distended, but it seems like it's not collapsing well, or it's not contracting. It just remains distended throughout both inspiratory and expiratory cycle. So this is a condition where you can see in a right side increased pressure, for example pulmonary hypertension or right heart failure, where there is a distended IVC. And again, it may be seen in hypervolemic conditions. One of the studies from the adult literature, especially in the adult literature, they were trying to compare the estimation of central venous pressure by assessing the IVC diameter and its degree of respiratory variations. So in adults, they consider diameter of IVC more than 8 millimeter, and if it is collapsing less than 50% difference in the inspiration and expiration is considered normal. But if you see IVC diameter was less than 8 millimeter and it's collapsing more than 50% with inspiration, that may be considered associated with very low central venous pressure, which might need a fluid replacement. If you have an IVC diameter less than 8 millimeter and the collapse less than 50%, it may be a low normal kind of conditions, and depending on the case to case, you may give a fluid. However, you have an IVC diameter is distended more than 8 millimeter and there is no inspiratory collapse, as discussed earlier, may be seen in it's a reflective of very high central venous pressure, is seen in right ventricular failure or any right pulmonary high pressures like pulmonary hypertension or hypovolemic conditions. Second, other things we can look in terms of the preload is looking at the four-chamber at the apical view and trying to see this. The LV is well distended, but how is the chamber distended in the diastolic phase of the cardiac cycle? So if you see papillary muscles kissing each other, like for example, or if the chamber is so crowded looking, that is a suggestive of low volume or low or underfilling of the heart. So that may be just a gross looking at it and say, yeah, the heart is underfilled and might consider need for some volume resuscitation. So kissing papillary muscle sign, where the opposing papillary muscle, especially in the left ventricles, if they come in contact each other at the end of the systole or at the end of diastole, is suggestive of severe hypovolemia. So to summarize, the features suggestive hypovolemia include collapse, inferior vena cava, or difficult to visualize IVC. You see all the four chambers of the heart look so small on the apical four-chamber view, or kissing ventricular walls at the end of diastole, and sometimes it seems like ventricles appear hypertrophied, like as they are so crowded, it looks like a thick ventricular wall, may be suggestive in some hypovolemic condition. And if you have ever calculated the stroke volume, they will be associated with low aortic and pulmonary stroke volumes. Let's talk about the cardiac contractility. So once the preload, next is the contractility. Cardiac contractility is a semi-quantitative measures of ventricular function. So an increase in contractility will produce an increase in stroke volume, especially if there was adequate preload and afterload conditions. Myocardial contractility, this depends on the end diastolic ventricular volume, that is your preload, as well as the metabolic milieu and the pharmacological factors of the condition, such as how acidotic the baby is, what the calcium level is, and is the baby on any inotropic support. So how to assess a systolic function? Maybe just by what we call the visual impression, just by looking at the heart. Is it contracting like a very hypercontractile, or is it normally contracting, or is it reduced function, or poorly contracting? That may be one way of visual inspection. This is most commonly used. And the other things are, we can use look at this picture from the parasternal long axis or four chamber view. Second is the exact measurement of cardiac function, systolic function, by measuring, for example, fractional shortening or ejection fraction. So let's look at the visual inspection of cardiac contractility. For example, in this particular view, when you look at cardiac contractility, so both the walls are contracting, and so normally longitudinally the heart contracts in the longitudinal fascias, and the chamber looks nice, well filled. Similarly, if you look at in this particular picture, heart is well filled and nicely contracting. But on the other hand, if you look at this particular picture, the heart is slowly contracting, the walls are just contracting, but not very much. And especially so in this picture is on the left ventricles are dilated and poorly contracting. Similarly, the left atrium was dilated. What about this picture? In this particular picture, this is the apical fourth chamber, little bit of foreshortened. This is the right ventricle and this is the right atrium. Both are distended and dilated, and the right ventricle is poorly functioning as compared to what you see on the left ventricle, which is nicely functioning. This may be often seen in a condition, for example, in pulmonary hypertension of the newborn in a severe forms. So, as we talked, cardiac contractility can also be assessed from the parasternal long axis view. As you can see how nicely the right ventricle as well as the left ventricles are contracting. This is the fourth chamber. So this is the two important views for visual inspection of how the heart is contracting. So for example, so this is one example of the baby we had. If you've seen this picture in the parasternal long axis, you see this is the right ventricle. This is the most anterior pore, and this is the left ventricles. What do we see is that left ventricle seems working well and contracting, almost coming in each other, but the right ventricular wall is dilated and is not contracting as much. On the long axis, this is what exactly we saw. This is the right ventricle is poorly contracting with the dilated and the distended both right ventricle and the right atrium, and your left ventricle is still functioning pretty good. So this is what we see in a baby with severe pulmonary hypertension. After starting nitric oxide, how does this changes? As you can see that now after starting nitric oxide, you can see the right ventricle is little bit more relaxed and contracted here, and similarly on the apical four chamber view you can see a difference in the contractility. That means improved contractility compared to the previous picture. And this is another example where you have contractility. This is normal looking contractility, and this is dilated and poorly contractile right as well as left ventricles. This is the biventricular dysfunction. That is as a eyeballing, what we call as visual inspection. Cardiac systolic function can also be assessed objectively by using shortening fraction, ejection fraction, and mean velocity of circumference fiber shortening. These are more advanced way of monitoring, has to be done by cardiologists and the neonatologists trained in the targeted neonatal echo program. So just to see what a fractional shortening is. Fractional shortening is the percentage change in the left ventricular diameter during the systole. So this is one of the most common methods used for measurement of cardiac systolic function. Fractional shortening is calculated by measuring first is just looking at what's the dimension of the left ventricle during the end diastole minus the what's the dimension during the systole. So I mean from the diastole how much is shortened during the systole. And the normal values range from 23 to 40% in a preterm babies, and at term it's from 25 to 41%. So just easy to remember, anywhere between 25 to 40% is considered normal fractional shortening. The nice thing about the fractional shortening is that it is independent of the age as well as heart rates. So that's one good thing. But sometimes the diastolic filling may be impaired due to a preload condition. If you have a poor preload and if you have a very severe afterload also, that might affect your distensibility or the diastolic filling of the ventricle. Of note, fractional shortening is not reliable in the first few days of life in neonate because of the high right ventricular pressure. It impairs the ventricular septal valve movement, so it may be remain static, so it may be a flat, so sometimes it may not be very reliable in the first few days of life, and especially in the presence of pulmonary hypertension. In those cases, ejection fraction is a method to assess the systolic cardiac function. So ejection fraction is the proportion of ventricular content which is ejected during the systole. It's somewhat similar, but it has been cubed to the factors we have measured for fractional shortening. Therefore, any small error in the measurements are multiplied t times. So therefore, it has to be very careful in calculating this ejection fraction. Secondly, it also changes with the shape of the ventricular cavity. For example, if you have a dilated cardiomyopathy where the ventricular cavity is hugely dilated or if the shape is different, it may not exactly give the appropriate. Fractional shortening should be preferred in the neonates, especially if there was no regional valve motion abnormalities and the septal motion was normal. Otherwise, in such cases, like a regional valve motion abnormalities or septal valve motion abnormalities, ejection fraction should be calculated by using a Simpson's plane. So this is how Simpson's method is. Ejection fraction is calculated by the end diastolic diameter and then minus the end systolic diameter times 3 divided by 100, and the normal ejection fraction is about 55 to 75% in children's. Third measurement is the mean velocity of circumference fiber shortening. Again, this is another measurement which is a preload independent and afterload adjusted measure of LV function. In the short formula, it's again more of calculation, and it's the fractional shortening times the left ventricular ejection time from the closure to the opening of mitral valve, the time it takes it. It is less sensitive to dimensional discrepancies. The normal value is about 1.5 plus minus 0.04 circumferences per second. Other more complex calculations which can do is the left ventricular output measurement. So cardiac output is nothing but the stroke volumes times the heart rate, and we can measure cardiac output based on the echo findings and knowing the cross-sectional area as well as the velocity time integral at the level of that particular outlet tract. And the normal left ventricular output is about 150 to 300 mL per kilo per minute. This may be helpful in understanding is it a hypovolemic condition or hypervolemic conditions. Just a short note about what are the things which is associated with cardiac function in asphyxiated baby. So there are two major patterns of myocardial dysfunctions in neonates with perinatal asphyxia. One, it may be a global decrease in left ventricular contractility, which is often seen with the decrease in fractional shortenings, along with decrease in cardiac output. Second, maybe they might also present like a moderate to severe pulmonary hypertension, resulting in decreased right ventricular output and the right ventricular dysfunction. Similarly, another condition where we might be interested in a septic shock, targeted neonatal echo or a bedside point-of-care ultrasound might help understand changing hemodynamics in neonatal sepsis by looking at both cardiac output, looking for preload conditions, the contractility, is there anything played by the opening of PDA, or does it have a pulmonary hypertension and any diastolic dysfunction. So various advanced methods can be used in a skillful hands for looking at it. But in short, for a point of care ultrasound, it's important to know is the preload sufficient, is the cardiac filling underfill or optimally fill, or is it the standard, as well as how is the cardiac function from the visual inspection. That's more important for general people. Thank you.